Hey, it's Dr. Alok Patel with Medscape. We're at the Society for Hospital Medicine 2019, talking to doctors about all kinds of awesome topics. Right now, I'm super excited because I'm talking to Dr. Dan Dressler and Lenny Feldman about controversial guidelines in internal medicine and in hospital medicine. Gentlemen, thank you so much for talking to us. I'm excited to hear what is controversial. What are the guidelines that are going to get people fired up to hear about?
So we're going to start off probably with diabetes guidelines. How do we manage diabetes, elevated blood sugars in the inpatient setting? And can we use oral hypoglycemics where the standard has always been, or at least has always been for the last decade? Oh, we've got to switch everyone off their orals and we got to put them on sub-Q insulin. We got to stick them throughout the hospital stay. So can we use orals in the hospital?
Those especially, or the sub-Q GLP-1 receptor agonists,
Right.
the exenatides, can you use DPP-4 inhibitors, the new drugs that everyone's excited about, but that we always stop when they come in the hospital.
Now, do you feel like there's a team sub-Q insulin and there's a team oral hypoglycemics out there?
So potentially, I would say the people in the U.S., the people on the end of oral hypoglycemics is a very small subset. It just happens that at my institution, I work with individuals who've been studying this, and so I'm on the side of being able to consider and use oral hypoglycemics in the hospital.
Persuasive. I like it.
Yeah, so for the purpose of the debate that we're having here at this meeting, Dan is for using the new medications, the DPP-4 inhibitors and the GLP-1 receptor agonists, and I am against it. I am for going with the old tried and true insulin and not trying any of this newfangled stuff on our patients in the hospital. Just use the stuff that we know works, and we know from actually most of the studies have been done by folks that he works with, so he should know this already. We know that the insulin works well in the hospital.
I may have to separate you two, but what's another controversial guideline you guys will be covering?
So the next controversial guideline is going to be related to transfusions and transfusion thresholds.
Which is something every hospital deals with all the time.
Oh, yeah.
Yeah, and a lot of us agree now that we can transfuse patients who get their hemoglobin less than 7 if they're healthy people. They're not having an MI, they're not folks with coronary artery disease. But the real controversy comes in as to when are you going to transfuse that patient who you know has coronary artery disease when they're sitting at 7.5.
You're just kind of...
Do we need to transfuse them, or they're 7.8, or can we let them ride?
Yeah, and this really even becomes a little bit more shaky when you have, someone who maybe not having an actual heart attack, but someone who's got heart disease. They have known heart disease, and some of the guidelines suggest, they need to be transfused at a hemoglobin 8 or below, versus, there's other data that might suggest that we can transfuse at below 7 or 7 and below. And so that's kind of our debate. And we see a lot of these patients. We see a lot of patients that end up in the 7.8, 7.2, what the heck do we do? And so this is another area, again, where Dr. Feldman and I are going to debate. I'm going to suggest that I'm better with lower thresholds.
And I'm going to say he's trying to kill people.
Again, there's going to be fire in this room. There's another controversial guideline, right? There's a third one that's going to be debated.
So the final guideline that we're looking at is an ACC/AHA guideline on syncope.
Okay.
And whether we need to get that echocardiogram in your patient with syncope who doesn't have the usual kind of concern for structural heart disease. But should we just be getting the echo on most of our patients who have syncope?
Lenny's a little bit...
And the other side.
Well, I mean, so Lenny's a little bit concerned because every participant at the meeting who's met him has passed out. And so he's ready to order
Echoes
more
for everybody.
Echoes for all.
The issue is this. I mean, in many of our hospitals may not even realize like an echo costs between $1,500 and $2,500. It's not like an EKG that's probably, $50 to $100 or less is what's being paid. I mean, these are expensive studies, and so if we go by the guidelines and being a minimalist, not everyone really needs an echo. I think going by the guidelines, you really want to suggest, well, what based on history, what based on physical exam makes me need to go that route, and if I go that route, it needs to be supported by one of those backgrounds.
Gentlemen, thanks so much for chatting with us.
Good to see you.